Good afternoon,
Have
everyone.
you given the control to us? Can
I
we
will
mute
be
you
giving
whenever we want to?
I will be giving the floor to both of you because we are going to talk about the stream and flow today. Very good afternoon to everyone who has joined, and we'll wait for 2 minutes maybe for more people to join. Meanwhile, I will just begin saying that uh, today's topic, it may sound like it is dry to some because it's only urinary tract infection mainly that we are going to talk. But I think it's one of the most common things that we as doctors see. And 5 to 6 years back, there was a time when we were lagging behind in picking up urinary tract infection. We would ask for a CBC, MP, CRP, but we would often forget to ask for a urine routine test in children. From that, we have come to a stage where I feel that every febrile patient in the OPD or in the IPD nowadays, we are asking for a urine test, probably thanks to our nephro ninja and our colleagues like Dr. Pankaj Deshpande and Dr. Amol and many other nephrologists. So, a lot of things were playing in our minds in the last 6 months. Every time we have patients of urinary tract infection, one is, are we in a stage where we are overdiagnosing every febrile child who has urinary tract infection and the urine shows few pustules here and there? And second, coming to the protocols, it's really very confusing for us, general pediatricians especially, because the protocols keep on changing every few months, and a lot of time we are left absolutely at sea that whether we should follow the ISPM guidelines or the NICE guidelines or the European guidelines, and whether we should do MCU or we have to do DMSA, and at what stage what to do. So at least for me, every patient, indoor patient especially the bad ones who are diagnosed with UTI, we are really feel very confused many times. So today's talk, friends, mainly is to flush all our confusion about a diagnosing urinary tract infection. What are the cutoffs, and what? How do we interpret the culture? How do we interpret the basic urine routine reports? Then coming to the treatment, whether 5 days of antibiotics or 7 days or 10 days, followed by second line of investigation, when and what, when to do USG, when to do MCU, when to do DMSA. And I remember a few years back there was an era where we used to give prophylaxis, night dose of Septran or night dose of Cephalexin for 6 months. In fact, Dr. Pankaj was, I worked with him in MGM Hospital, Vashi, and he remembered that he had only taught us to do these, and we were doing. So we want some clarity as general pediatricians on urinary tract infection. And today we have two wonderful nephro stars with us. One is my very dear friend, Dr. Pankaj Deshpande. And we started our journey together in MGM, and it's more than 2.5 decades. And he's like, Kaun Banega Karodpati, still my, friend to go when I am stuck with any nephro doubts. And Dr. Amol Madhave, whom I didn't know 5 years back, but last 3 to 4 years, he has been in Kokilaganamani Hospital in our team as our pediatric nephrologist. And he's always there, and together we have managed many pediatric nephro complicated patients. So I have two wonderful speakers, and without wasting any time, I think I will request them to start with their presentation. I request all the attendees and doctors who have joined that we can have questions in the last 10 to 15 minutes. So request you to put your questions in the chat box, which we can take. So off to Pankaj. I didn't talk much.
Oh, you didn't. Shall I share my slide? Yeah. Can you see the slides?
Yes.
Okay. So thank you for the introduction. I'm not sure that I will be making it any more simpler. What I am actually going to do is allow you to use your gray cells to decide what needs to be done. So as I put the topic there, it says UTI guidelines in daily practice. As Dr. Shilpa said, there are multiple guidelines that are written all over the world. And we have got recent guidelines from India also, which tell you about what to do. Now, remember, the name itself, guidelines, is to guide you as to what is to be done. It is not gospel. Unfortunately, we start using this as gospel, that it is mandatory that this has to be done, and that's where problems occur, because there is no change or there is nothing that can replace your thinking gray cells. So between the two, which one is better, using your logic or बहुत सी किताबें पढ़ गया. I don't think the younger generation will know which film I'm talking about when I put the poster up there. But this is what is happening. We read about the guidelines. So let's find out whether reading a lot of these guidelines helps us, because application of guidelines in our daily practice exposes the strength or the weakness of the written word. And who better to teach us this than our patients? So all the cases that I'm going to talk about are the patients, are real patients. These are patients that we see on a daily basis. So let's start off with the first one. So this is an 11-month-old boy, and I hope some people do respond to the questions that I ask in the chat box. So this is an 11-month-old boy who has history of fever for 1 day. The child is otherwise well, he's playful, he's active, and there's no past history of urinary issues in this boy. However, there is a history that this child had antenatally detected cysts in one kidney, and it was confirmed to be a right multicystic dysplastic kidney after birth. And he is being followed up with an ultrasound done every 3 months, 6 months, which is showing that it is involuting, but he is otherwise well. So now this child is seen in the evening. He comes to your OPD. He's a well-grown child. You examine him from head to toe and you don't find any focus. The child remains playful and active in your clinic. His blood pressure is normal. And so that brings us to the first question that we have. So this is a boy who has fever without focus, as per the teaching that has been thrown at us for all these years. A child coming with fever without focus, we should send a urine routine or send a urine routine and culture.
We do first urine routine, and then depending on what is the urine routine, send the culture.
Just a few months ago, the answer is yes and no. It's the kind of help, and I'll explain what I mean by that. Let's find out what happened to this child. So this child had a urine routine done, which showed a specific gravity of 1020, a bit of protein in the urine. Pus cells were 10 per high power field, and the RBCs were 1 to 2 per high power field. So again, the question now arises, we label it as a UTI. Do we send a urine culture? Do we start antibiotics? I'll keep going ahead. So do the guidelines help in this particular scenario? I'm saying absolutely not, because there is a key word in the guidelines which is not read when we look at these guidelines. The guidelines do not help at all in this particular scenario. What happened to this child? Let's look at what happened to the child rather than looking at the guidelines. This child never had fever again. The child had fever only for 4 hours on the first day before he came to your clinic. He never had fever after that. There were no antibiotics given to this child. He had received 1 dose of paracetamol for the fever at that time. And he came back to the clinic 48 to 72 hours later, because pediatrician obviously had said, come back and let's see what's happening. Now, the child was asymptomatic completely, but had a urine routine done. And what did the urine routine show? It showed 15 to 18 pus cells, no RBCs, and a trace of protein. Now, this is where it gets confusing. Shall I call it a UTI? Shall I start antibiotics? And if I don't know, shall I go to the guidelines and now look at this and ask the guidelines, please help me in deciding whether it's a UTI or no? Unfortunately, the guidelines do not help you at all. The short answer is this child never had a urine infection. The urine tests, I'm talking about two aspects here. I'm talking about the second aspect. First, the first aspect I'll talk after the second case. So a urine test where done when the child is asymptomatic does not have any significance. So the second time when the child was seen and had no fever without focus or any urinary symptoms, you can send a urine routine and you can have 50 to 60 pus cells. We have had patients like that, and you do not act on it because this is normal. We treat the patient, not the report. That report has no significance whatsoever. As far as the first urine is concerned, when there was fever and the urine test showed a few pus cells, we'll talk about it when I finish the second case. So this is a second child who's a 7-month-old girl. And I saw the girl because they came to me with a history of abnormal urine reports. There were no symptoms. So this child had no antenatal or perinatal problems. There was 1 day of fever at 3 months of age. And I'm not sure what was there at that time, whether the child had a URT or no. The child had 1 or 2 doses of paracetamol. It is difficult to elicit the history. No antibiotics were given at that time. The child was playful and active, and a urine routine done on day 1 had shown 8 to 10 pus cells. Now, they had started antibiotics but sent a urine culture which showed no growth. But this child got treated as a urine infection. So the same kind of history as the first one, but this one got treated as a urine infection. A urine routine repeated after 7 days of cefixime showed 15 to 20 pus cells. Now they said that the UTI has not cleared, so they gave a course of different antibiotic. Now this had been going on for the last 4 months. And I'm literally telling you it was 4 months. So every 15 days, the child was getting a different antibiotic because the urine routine never became clear. It always showed 8 to 20 pus cells. So including oral ferropenem was given. Now they also sent cultures in between. Sometimes it showed 1,000 organisms, sometimes 10,000 organisms. And this child had been on antibiotics for the last 4 months. They did an ultrasound twice, which confirmed cystitis. And now the child had 15 pus cells, and that is the reason I was seeing the child. Now, what would you do at this stage? Would you admit this child for IV antibiotics because the UTI has never cleared? And after that, would you do a micturating cystourethrogram because this child has reflux and is therefore getting repeated urine infections? If you are going to go to the guidelines to read, you're not going to get answers because they are not clear in terms of this aspect of urine tests and when to be done. In fact, the colony count here, as Dr. Shilpa was talking about, will actually mislead you because 10 raised to 4 is now considered as a urine infection. So you are going to get yourself into worse possible situations because of what is being written. This short answer is this girl never had a urinary tract infection. So let's analyze what we mean by a urine culture or a urine infection. Forget about the guidelines, whether it's said by NICE or ISPN or our Indian guidelines. So what is the definition of a urinary tract infection? Now the definition itself has evolved. So you have the initial definition was if you had a significant growth on urine culture. And what was a significant growth? It was 100,000 organisms or 10 raised to 5 organisms per ml of a single species in a midstream or a clean catch urine sample. Then they realized that you can't have only this. In a child who did not have pus cells, if you get a growth, that is not significant. So what they said is now you need to have significant pyuria. So what is significant pyuria? Significant pyuria is more than 5 pus cells per high power field of a centrifuged urine sample or more than 10 per cubic millimeter in an uncentrifuged urine sample. Now, is that definition enough? No, because now what you need to add to it is the fact that the child should have symptoms that suggest a urine infection and then should have this. Otherwise, you're going to keep on doing these tests in all patients. There There was a study which looked at RSV positive patients who had a urine routine and culture done, and they were labeled as having a urine infection. Whereas they never had a UTI, it was simple RSV bronchiolitis. So unless you have the symptoms that suggest a urine infection, you will not do a urine test. And what are the symptoms? You need to have either urinary symptoms or fever without focus, especially in an infant or a child less than 2 years of age. Now, this is a slide that I put up in every talk of urine infections because this is what everyone needs to take home, irrespective of what the talk is about. How do you collect and interpret urine? So the first line is the most important in a child suspected of having a urine infection. So if a child is asymptomatic, you will not do a urine test. If a child has a focus that is explaining the fever of the child, you will not do a urine test. So only if the child has fever without focus or urinary symptoms, you will clean the genital area with normal soap and water. You will collect either a midstream or a clean catch sample, which should reach the lab within 1 hour. And in girls, you will make sure that there is no vulval redness. Now, in such a case, if you get a growth of 100,000 organisms per ml of a single species, it is definitely significant and suggestive of a urine infection. Now, the problem here comes is when do you suspect a urine infection? So as we said, urinary symptoms, and I'm not talking about that altogether because urinary symptoms, we all know about it. With or without fever, the UTI mimics to be remembered, and I'll talk about it some other time. What I'm going to talk about is fever without focus because of these children who come to the clinic. Every day you see these patients in your clinic. So when we say fever without focus, we need to understand the presentation of the child. So when is the urine sample sent? And if I take a poll of all the doctors who are sending urine samples for a child having fever without focus, I've taken this multiple times and there is no uniformity. So some people will send it at 24, some at 48, some at 72 hours, and some at 96. So how do you expect that you will be able to diagnose a urine infection when we are not sending the samples at the time when we are supposed to? So how do we get over this? So let's analyze. The fact is you have fever without focus. What is the incidence of urinary tract infection in these infants? If you looked at all the papers in the past, the incidence of UTIs was believed to be around 10%. Now, when the more robust criteria have been added, it has come to about 5 to 10%. It's not 50%. So that's what we need to understand. And again, these are based on a urine culture that is positive. So several studies done even in the casualty show that most children having fever without focus are likely to have viral infections and not necessarily UTIs. Now, when to send the urine sample is a very big dilemma. The Indian guidelines, I'm talking about the old guidelines. The new guidelines have some clarity, yet they don't have clarity, as I will explain to you. They do not differentiate between a well child and a sick child. So if you have a child who looks well, playful, active versus a child who looks sick, there is a distinction that needs to be made, not in terms of whether he's got pyelonephritis or a lower UTI, in terms of whether the child has a UTI or no in the first place. And secondly, when to send the urine sample. The recent guidelines are now saying that if you have 48 hours of fever without focus, then you send the urine sample. This is the latest Indian guidelines that I'm talking about. So in both these cases, the fever was only for 1 day. So yes, if you follow the guidelines, you shouldn't have done a urine sample. But now that you have sent a urine sample, what are you going to do? And this may not be done by you. Some other person, if the child goes to a GP or a different pediatrician and they have sent a urine sample on day one, and the child comes to you with the report, what do the guidelines say? Are they telling you what to do or not do? Unfortunately, they do not. They are only saying that you need to send it after 48 hours and not what to do in case you get a sample before that. So for that, we need to use our logic. So the same American guidelines, which everybody is very fond of quoting, before they even start talking about urinary tract infections, what do they say? They say it is reasonable to follow up a child who looks well but has fever without focus till the fever disappears without a urine test. You don't do a urine test if you are sure that the child is looking well. Or the criteria that are present for the risk of UTI are not satisfied. I'm not saying you need to do this. What I'm trying to say is this is what they have said. What the Indian guidelines unfortunately don't differentiate between a well child and a sick child. So what are these criteria? There are multiple criteria in the world. I put one of those screening tests, Gorlick and screening test for UTI. What they said is if you have fever more than 39 degrees centigrade, fever present more than 2 days, 5 days in some papers, a past history of a UTI. Now this past history in India becomes a big problem because of the second child that I told you. The child was already labeled as a UTI. So then when the child comes next time, if you do a urine test on the first day, you are going to get into trouble. If the child is younger and because these were Caucasian, the race of the child matter. We know that pyuria can be seen in many causes. So fever due to any cause, dehydration, if you have vulval redness, if you have hypercalciuria, if you have any kind of nephritis, you will get pyuria. So pyuria by itself doesn't tell you about urine infections. What about the culture? Now, the same American guidelines before they reach treatment of urinary tract infections are telling you very categorically that 0.7%, so roughly 1%, 1 out of 100 infants have a positive urine culture taken at any time. So without any evidence of urine infection. So what they did was they actually repeated the sample 3 times in the same child and they still found it to be positive. So it's not necessary that you have a positive urine culture and it's a urine infection. There are microbiome studies also, as the second line says, forget about that. But this bladder is not necessarily always sterile. Secondly, the most important fact for us as pediatricians, we need to understand that this is a study that compared urine culture done in the same children with suspected urine infections. So they sent a clean catch midstream sample and they sent a suprapubic aspirate also. And what did they find? That only 35% of the midstream or clean catch samples actually had a UTI based on the suprapubic aspirate. The rest of the 65% on a suprapubic aspirate did not have a urine infection. The rest were contaminants. So where does this leave us? What is the solution? How do we get out of this? So either you send a late sample. So late sample for our guidelines means 48 hours. In other papers, it's 72 or 96 hours. Or there is a simpler algorithm which I have set up. And this is a very complicated slide. I'm not talking about the entire slide. All I'm going to talk to you about is this particular. So if a child presents having fever without focus and is unwell, there is no question you are going to send a urine sample off and start antibiotics. There is absolutely no doubt in the world. But if the child presents having fever without focus but looks well, playful and active in your clinic, if you do send a urine sample or you are seeing a report that has been sent by somebody, if there is no significant pyuria, you don't need to act. But if there is significant pyuria and everybody is worried, you can send a urine culture, but do not start antibiotics. Follow this child up daily. If the child keeps back coming to you and the fever continues till the culture report is available and the culture is positive, you treat it as a urine infection. If the fever settles down and the culture is negative, obviously it's not a urine infection. But if the fever settles and the urine culture is still positive, please do not treat it as a urine infection. Because this is not a urine infection, this is just collection problems that you are having. So you can follow up this child. If the child develops fever again in the next few days, you can start antibiotics, or if the child looks sick at any point, start antibiotics. So on follow-up, if the second day you think the child looks unwell, you can always start antibiotics. But do not start antibiotics right at the outset because this child probably doesn't have a urine infection. So we need to understand that a small percentage of children having fever without focus actually have urine infections. And if you keep on using antibiotics indiscriminately, please understand it's very harmful for all of us. And this may sound like an overstatement, but remember 20 years ago, 25 years ago, the treatment of choice for a urine infection was amoxicillin. Today, nobody uses amoxicillin. No guideline talks about using amoxicillin as a single antibiotic. That's the kind of resistance that we are talking about because of use of antibiotics. So we understand that pyuria has non-UTI causes, and a positive urine culture is not always a UTI unless the child has symptoms. One of the lines that I put in the presentation said that the UTI was confirmed as cystitis on an ultrasound. Don't get misled by this. On this slide, on the left-hand side, if you see, it says urinary bladder there, and it gives you wall thickness. And that is clearly more than 2 millimeters. On the right-hand side, it's the same bladder, and now it has become thin-walled. What do you think is the difference between the two? The difference is that if the bladder is not full, then it is going to look thick-walled, and the radiologist is going to report it as cystitis, thick-walled bladder. So just because ultrasound says it, it is not a urine infection. So you need to keep asking for pre-void and post-void urine. Bladder capacity, you can use different formulas. One is age multiplied by 30, or you can use age plus 2 multiplied by 30. But unless the bladder is completely full, you won't be able to comment on the thickness of the bladder, and you'll keep on diagnosing cystitis. The other important issue is don't repeat the urine sample if you have given a course of antibiotics to see whether the UTI is resolved. If the child is asymptomatic, any number of pus cells being present does not carry any meaning. The same thing, surveillance samples done every 15 days, every 30 days when the child is asymptomatic has no meaning whatsoever. Don't do it. Do this urine test only when the child is symptomatic. So you may be doing a urine sample 4 times a month or once in a year, depending on what the symptoms are. The other ultrasound reports that often throw you off and make you think about a urine infection is floating debris in the bladder that suggests cystitis. Unfortunately, no. Infection is one of the causes, but the commonest cause is usually inadequate fluid intake and mucus and phosphates in the urine. One of the other things which I will talk about in the next case, I've got a few minutes left, I will finish off a couple of cases. The kidneys, even though they look normal in size, increased echogenicity of the kidneys or grade 1, grade 2 medical renal disease, everybody thinks of pyelonephritis. No, it's not. We will talk about it. So diagnosis of urine infection is based only on urine tests, not on ultrasound scan. Only a bit of protein or blood in the urine is not evidence of urine infections. And you cannot have pyelonephritis ultrasound changes with no symptoms whatsoever in a normal urine test. These are the different causes of increased echogenicity. Pyelonephritis is just one of them. There are many other causes like interstitial nephritis, acute nephritis, nephrocalcinosis, dysplasia, etc. The next child is a 13-year-old girl who got admitted to the hospital because there was a history of fever and abdominal pain. Now, you need to understand the history in a child before you start labeling the child as having something. So this child had fever and abdominal pain for 2 days. The fever was high-grade fever. There was no dysuria, no significant past history. The child had taken treatment outside, and as the fever, no antibiotics, as the fever did not settle in 2 to 3 days, the child was admitted. The child was well grown. Blood pressure was 110 over 70 millimeters of mercury. There was no specific abdominal tenderness, but complaints of pain. And on the second or third day, it actually was left hypochondriac pain. There were no other significant findings. These were the tests that the child underwent. Hemoglobin was 12, white cell count 12,300, platelets 2.1, creatinine 1.8, clearly elevated above the adult level also. A urine routine showed specific gravity 1005, 1 plus protein, 15 to 20 pus cells, and 2 to 4 RBCs. So the question is it a urine infection because you're seeing pyuria, you've got raised creatinine. Now this child also underwent an ultrasound scan which showed increased echogenicity in both kidneys grade 1 to 2 medical renal disease. And the bladder is normal. So the thinking process then becomes, does she have a urine infection, which is pyelonephritis, and hence the ultrasound is abnormal, and hence the child has a raised creatinine. If you go and read guidelines, you're not going to get an answer because guidelines are not very clear in such a case. What you need to understand is, let's analyze. This girl never had a urine infection. The abdominal pain was not suprapubic. She never had dysuria. In an infant or a child who's 2 years, 3 years, we are worried about urine infection because they cannot give you complaints of dysuria. In an older child, to have a urine infection without dysuria is very, very, very uncommon. So what is actually happening in this child? This girl actually had a urine culture which was negative. So what are the changes that we are seeing? What this child, remember the urine routine? It showed dilute urine, 1005. So what this child had was acute interstitial nephritis. The ultrasound changes are bilateral. In pyelonephritis, you are more likely to have a unilateral. You get UTI in one kidney. Why would you get it in both kidneys? And some of these children, I mean, if I come back and give a talk only of this, some of these children have undergone a CT scan or a DMSA scan. Again, they show bilateral changes, not unilateral. This tells you that this is not a process which is likely to be pyelonephritis. This is acute interstitial nephritis, dilute urine. If you waited for a little while, you might see sugar in the urine, you might see eosinophils in the urine. And the cause was this child had taken NaCid for the fever at onset. Single dose. And that's why this had happened. All that you had to do was wait, and the creatinine settled back to normal in the next 72 hours. And what is the clincher for diagnosis? You get a beta 2 microglobulin in the urine, which is 8,271. The normal level is less than 300. So this child had tubular inflammation causing the symptoms and the urine reports. So every fever with every pyuria with fever is not UTI. Remember, raised creatinine is not always pyelonephritis, and bilateral changes on ultrasound. Be careful because acute interstitial nephritis is quite common despite what the textbooks teach you and any other person may be telling you. The last one, this is a 1-year-old boy who had no past history. He had history of fever without focus lasting for 3 days. He had a urine routine done which showed 15 to 20 pus cells, was treated as a urinary tract infection. Urine culture showed 100,000 organisms per ml. Now, this child remained well after treatment and had an ultrasound scan. As we usually say, ultrasound scan should be done within a week in a child with UTI. When admitted, if you have admitted the child, a DMSA scan should be done 3 to 6 months later, preferably later, and an MCU only when it is indicated. This child had a creatinine which was 0.4. And so the question now arises here because of what the guidelines are telling you recently. So if you take the guidelines, so what you should be doing, you should obviously be giving general advice about preventing urine infections. And the question is, would you do any other tests? And if so, when? The guidelines say that if you have a single UTI and the ultrasound scan is normal, you do not need any further tests. Now, this child, we did a DMSA scan 6 months later. And this is the DMSA. As you can see, one of the kidneys looks very small there. This is despite a normal ultrasound scan. That's the point I'm trying to make. So the report said left kidney normal uptake, right kidney diffused, reduced uptake. Left function was 76, right 24%, and the report said scarring in the right kidney. The message is normal ultrasound does not have any meaning for function of the kidney. So you can have perfectly normal looking kidneys, but an abnormal DMSA scan. The reduced diffuse uptake is not scarring because nuclear medicine scan people have not gone beyond scarring ever. This is right renal dysplasia. And this is the DMSA you would have seen even before the child got a urinary tract infection. This will never be picked up without doing a DMSA scan. And this child needs long-term follow-up because the whole idea of seeing a child with a urinary tract infection is to decide whether you are going to keep a long-term follow-up or no. Otherwise, what are we doing? We are giving antibiotics and sending them home. That has no meaning. Now, these are the children who are going to be at risk in the long term for developing hypertension or renal dysfunction. And what you need to do is get a creatinine, a protein creatinine ratio, and a blood pressure long term till they cross puberty, at least 18 years of age. So finally, to finish off, so just because you have guidelines doesn't mean you should lock away your logic. You need to keep using your logic so that you can say elementary, my dear Watson, rather than किताबें बहुत सी हमने पढ़ ली है. Thank you.
Hey, Pankaj, after this talk, I feel all these years I'm treating all UTIs wrong. And what is the point of then having guidelines? I mean, the latest 2023 ISPN guidelines have come. And at this rate, I feel that every patient of UTI I have to refer to the nephrologist only. So
No,
I
but
have few genuine queries from the talk. It says that fever without focus, then you do urine routine at 48 hours. Now, we all know, being pediatricians, that in infants, in toddlers, they don't come with symptoms saying, I have burning micturition, I have dysuria. Okay, fever with vomiting is the most commonest presentation and symptom of UTI in babies. So when you are saying that in only when the symptoms are there in a febrile patient, we need to do the urine routine sample, but it is so difficult to get symptoms of UTI in
you're not getting. Again, I said you need to differentiate between a well child and a sick child. A child who's having vomiting and is sick with fever, nobody's saying don't do a urine test. This is not the guideline. This is I am telling you. The guidelines are saying entirely different. I am telling you, if a child looks sick and has fever, do a urine test. Who's telling you don't? And start antibiotics also. Send a urine routine and culture and start antibiotics. If the child is well and playful and active and is sitting in your clinic playing with your toys and throwing your toys away,
Yeah, but if
are you
still
really
the child is having 102 fever, no respiratory symptoms, okay,
correct?
so clinically I'm not having any other focus. So then
Even
I
your
will definitely
guidelines say
ask for
40.
a urine routine.
Even your guidelines say 48 hours. Otherwise, you're going to get into trouble because most infections are viral. You are going to get pyuria. So you're going to keep on treating these as urine infections. So the fever might settle down in the next 24, 48 hours. How do you know? So nobody knows. So that's the reason why these guidelines have come up. And there are criteria for deciding when to send a urine test also. So what the guidelines are doing at present is they are saying wait for 48 hours having fever without focus. What they haven't qualified is in a well child. In a sick child, you don't wait. So if you have to admit the child, nobody will say wait for 48 hours and then collect a urine sample.
Then the sample within 1 hour. Now, a lot of time we tell them to collect the. First, you tell me, is it we always say first morning sample? Do we still follow that protocol of first morning sample, or any random sample is fine?
Any sample is fine.
So again, if the patient is going to collect at home, process in 1 hour is practically very impossible, because he'll collect at home, then the lab will open, they may not have a easy accessibility to the lab. So all these things, practically, they are very extremely difficult.
If there is going to be a delay in the sample reaching the lab, then it should be kept in the fridge at 4 degrees centigrade, not in the freezer. So up to 24 hours, the urine can be stored.
Preeti is asking, sir, if a well child comes on day 4 of fever, do we wait for 48 hours and observe or send urine?
Already you've got 4 days of fever. No, it's not when the child presents to you. It's fever of 48 hours.
Can I ask a question, Subhash? Here?
Yes. Whether I can answer, I don't know, but you can ask.
Is that time, Shilpa, or afterwards?
Yeah. Ask.
We can take 5 minutes question before Amol's talk, because I need 5 minutes to digest.
So, Pankaj, I want to ask you that you said that if there is fever more than 48 hours, you send urine, etc. Urine is showing about 30%, but the culture comes negative. Now, do you treat it as urinary tract infection or no?
You will have, no, if you have waited 48 hours and your urine shows 30%, you will have already started antibiotics.
Antibiotic, yeah. But then we take it as a UTI.
Don't label it as a UTI. If the culture is negative, the gold standard of labeling somebody as having a urine infection is the culture has to be positive.
Okay, so if the culture is negative, then what? We label it as what?
Then it has to be something else. I can't tell you what it is.
Acha, acha, okay.
You will have something else causing the fever. So you get pyuria in every different case. We recently had a child with 55 cells in the urine, and it wasn't a urine infection. It was just a URTI.
So if the culture is negative, do I continue the antibiotic which I started for UTI as a first line, or I stop the antibiotic?
No, ideally you should be stopping, but it depends on what you find in the child. No, why do you think the fever was there? So I think to make a statement, stop antibiotics is not entirely right. It depends on the clinical situation of the child, because clearly there was fever in the child. There is some cause for the fever. So if you feel that fever was viral in origin, what we are saying is it's not a urine infection. But clearly there is some cause for the fever. So if you are happy that it was viral in origin, stop antibiotics. But if you think that it is still bacterial with some other origin, then it is a call that the pediatrician will have to make.
Yeah, Pankaj, second question is that less than 2 years, you said sonography normal. Every patient you should do a DMSA after 6 months. Better.
If it is a proven urinary tract infection, I would still go with the old guidelines that try and get a DMSA done 6 months later, because you want to decide whether to keep this child under follow-up or no.
Okay. And sonography can be done immediately following a UTI, or we wait?
Yeah, that's what I said. In a child who's come to you on an OPD basis, and you think the child has a urine infection or you're treating a urine infection, get the ultrasound within 1 or 2 weeks.
1 or 2 weeks, not immediately.
Immediately meaning next visit you tell them do an ultrasound and come.
No, what I mean is that urine shows pus cells, tomorrow do a sonography and come back to me. That's what I meant.
Makes no difference.
Makes no.
If the child on an OPD basis, no. If the child is admitted, that means the child is sick. Then do it during the admission. So before you send the child home.
I think time for to have Pankaj guidelines for UTI, I think.
Listen to what Amol also has to say.
Sir, I have a doubt.
Yeah. As I said, you can ask doubts. Whether I can clear it, I don't know.
So, sir, recently we had a 7-year-old child with autism. She had all the symptoms of suggestive of a urinary infection like dysuria, frequency, urgency. But the urine routine was bang normal and the USG showed cystitis. Now, how to interpret this?
What was the pre-word volume?
Okay.
So
they did not mention,
Your child with autism, you said, no?
Yes, sir.
Had was detrusor instability. That was not a urine infection. They commonly have that.
Okay.
She had very severe pain while maturating, actually. And
yeah, they will get, if they are voiding 50 times a day, your urethra will pain. Your urethra is designed to pass urine only 8 times a day at the most.
What about the sonography showing cystitis? Then it is all hoax.
No, it depends on what it's based on. If your pre-void volume is showing that the bladder is full and they are saying it's thick-walled bladder, then it makes sense. If it's a collapsed bladder, which is not even half full, and they are saying it's thick-walled bladder, therefore cystitis, it clearly has no meaning.
Okay, let's listen to Amol's PPT.
I have one more doubt, ma'am.
Yes.
So, sir, often they report it as internal echoes in the bladder.
I said that. You're not listening to what my talk is.
Sorry.
Floating debris, internal echoes are the same thing. So most of the time, I haven't, and I'll tell you, I won't name, but there are so many doctors whose children have that kind of an ultrasound report, and it's only because the children are not drinking enough water. They do not have urine infections. Take it from me.
Sir, and LE and nitrite in the urine report, whether to actually consider?
Again, the symptoms are more important than the actual test. Your LE, you're saying leukocyte esterase is basically pyuria. And nitrite test, if you leave a urine sample out on your room temperature table for more than 1 hour, it will grow contaminant organisms. So you say take a urine sample and you're going to send it down to the lab to get a nitrite test done. Useless. So you do the urine test yourself, it is significant.
Okay. Thank you, sir.
Amol, let's hear you out.
Yeah, I'll mute myself. I'll stop talking.
Yes. I'm unmuted. So what I am going to discuss is probably what exactly Pankaj sir said, but maybe all of us are not lucky to have a pediatric nephrologist attached our setup. So if I get the guideline in my hand, and if there is nobody to help me how to interpret the guideline, I mean how to interpret that guidelines, which are the recent guidelines, with maybe not one pinch, but a lot of pinch of salt. Okay, so I'll just start sharing the screen. So is the slide visible now?
Yes, yes, it's visible.
Okay. So we will see what the guidelines, and the basic guideline that I have taken as a base to discuss everything is our Indian Society of Pediatric Guideline of 2023. Now, what are the new things that they have added is they've changed the way UTI is diagnosed, they've changed the therapy, they have become less aggressive in terms of imaging after UTI. They have told us what to do with recurrent UTI, partly just touched upon bladder bowel dysfunction and other things like VUR and renal scarring and the advanced treatments. So if we look at any kind of febrile UTI, more so pyelonephritis, UTI is initially in the earlier ages is more common in boys. As say about median age of 6 months, the girls start getting UTI more commonly. And about 1/3 of these children who have first episode of febrile UTI land up having maybe some congenital anomaly. Now, some congenital anomaly does not always necessarily mean reflux. Like I said, it could be just a dysplastic kidney which is there. We need to not miss out these children when we are evaluating these children when proven that it is UTI. So let's see, like this 3-month-old child, infant, who came with fever of 3 days duration, which is high grade, and poor feeding. Like we said, since it's a small child and it's poor feeding, I need to keep in my mind other possibilities like sepsis or meningitis or UTI before I start sending investigations. So if clinically indicated as a part of fever workup for this small child who's absolutely sick looking and who's probably indoled, I will send a urine routine. Now, one thing to remember, like what Shilpa ma'am said, that children do come with just high-grade fever and vomiting. That's probably the most common presentation of a urine infection in younger children, especially infants. So there could be a lot of non-specific symptoms, especially in newborns, like prolonged neonatal jaundice or the temperature variability which is there. They could present with poor feeding and poor weight gain, and sometimes just irritability and listlessness. So this child had no other localizing sign, and we decided to send a urine routine. Now, coming to this question, what Dr. Preeti asked, that we always look at pus cells. So yes, pus cells do indicate that it could be UTI in clinical context. If there is no other localizing sign, if the child is sick, and if it is showing pus cells, if I'm not pressed, if the child is an older child, relatively stable child, I can await the urine culture if there is no localizing sign. And I have to outweigh the risks and benefit of waiting to start antibiotic or not. Now, coming to nitrites and leukocyte esterase, these are surrogate markers for pus cells and nitrites and urine infection with organisms. So the recent guideline, the ISPN guidelines say that this should be your first screening test for UTI. Because culture will come after 2 days. How do I decide whether this is UTI or not UTI? So combined nitrite and leukocyte esterase could be fairly okay to diagnose or label a child as probable UTI, but you have to also remember that the interpretation is in clinical context. The advantage of these two tests are they are highly specific, they are rapidly available, and they indicate inflammation. Like Sir said, pus cells can be present because of any inflammation that happens in the kidney. So if once my pus cells are there, my leukocyte esterase is going to come positive. It just tells me that there is some inflammation happening in my kidneys, which I have to prove by culture that is it or is it not a UTI. If given an option, after the screening test, if I could get a microscopy done, which shows me pyuria and bacteriuria, probably that could be an alternative test for screening for UTI. Now, one thing is, when we talk of nitrites in urine, it takes some time for the urine to be there in the bladder before the nitrate gets converted to nitrite in presence of an infection. So in newborns and infants, what happens is, since they're voiding more frequently, the urine does not stay in the bladder for that long time. So probably there is an inadequate time for that nitrate to nitrite conversion. So if my nitrite is negative, and in a smaller baby, in an infant, I need to be careful of interpreting this. Also, there are fixed specific organisms which will give this nitrite positive. There could be some atypical organisms which do not reduce nitrate. Sometimes a UTI with non-E. coli organisms, for example, will give nitrite negative. And there are chances of false positive leukocyte esterase, like dehydration or any inflammation happening in the kidney. So I need to interpret these screening tests with little pinch of salt. Now, like we said, that guidelines suggest that treatment should be commenced within 48 to 72 hours of fever. They have mentioned the line that delaying antibiotic therapy has been known to show increase in the risk of kidney scarring. Now, to read the statement looks very, very scary. Now, something has come positive. I don't yet have a culture report. So I might just start antibiotic. I could do two things in this situation. See how the pattern of fever is. Is this child getting sicker with every day? If this is the OPD child, if I send this child back on OPD basis, I think it is reasonably okay to wait to start antibiotic. If this child was well playing around, like we said in the OPD, we can reasonably wait to start antibiotic. But if this child is sick looking or a infant, neonate, then probably I will send a urine test. If the child is small and sick, maybe start antibiotic and then see how the child behaves. So, like Shilpa ma'am said, no, are we over treating symptoms with antibiotics? Are we labeling everybody as UTI if pus cells are there? Probably yes. Probably yes. And in that situation, we need to see how the symptoms evolve. Are there any symptoms of lower urinary tract involvement? Is there some dysuria? Is there some hesitancy in passing urine? Are there other bladder bowel symptoms that are there in presence of current episode of fever? So in such situation, maybe it's our clinical judgment that decides whether or not we should start antibiotics. So that's what, this is the basic clinical teaching that we have been taught for so many years. Look how the symptoms evolve. Now, if the patient is of extreme age, neonates and infants, probably in them, probably worthwhile starting antibiotics. But that too, again, if the child is sick enough to be admitted, not on oral basis, OPD basis, and look for signs contributing to developing UTI. Now, if we have sent a urine culture and the culture came back as 10 to the power 4, now is this UTI? When we were students, the cutoff was 10 to the power 5. Now, recently, this new guideline that has come has lowered down the cutoff to saying 10 to the power 4. So this is the comparative chart of what the previous guideline and the recent guideline said. Important is the presence of pus cells, the leukocytes, is not necessary to label a child as UTI. And it has to be a growth of single bacterial species. Now, if you look at suprapubic, previously we were always taught that a suprapubic puncture through any organism is to be taken as UTI. The recent guidelines, I'm sorry for the error in editing, that is 10 to the power 3. So now they say that any growth to the tune of 10 to the power 3 is to be taken as UTI, because what we know that bladder is not completely sterile as an organ. It still might have organisms which might grow. So now suprapubic aspirate, if it grows more than 10 to the power 3 organisms, it is to be taken as UTI. Catheter sample remains more or less same, 10 to the power 3 to 10 to the power 4. And for midstream sample, previously rigid criteria of 10 to the power 5 has now been brought down to 10 to the power 4 to 10 to the power 5. So this is the change that has happened in the new guideline. This is the kind of flowchart that the new guideline gives. Again, perform dipstick. Now, I do not agree with perform urine culture and dipstick together. Okay, dipstick, that is meant to be your screening test. The dipstick shows me something like to the left of the screen, if you see the leukocyte esterase or nitrate is positive, what they say, start empirical antibiotics. I'll be very, very cautious with this. I'll want to see how the fever evolves. If the child is an older child, is otherwise okay, I will wait. So I do not agree with the point that start empirical antibiotics. Yes, but if it is negative and the child is small, I will look for risk factors. On the right hand side of the screen, I've written down those risk factors. That this child has some bladder bowel dysfunction, probably constipation that is happening, maybe a previous history of UTI. But this risk factors that they mentioned, we don't know if somebody who saw this previous history of UTI or previous episode of UTI, was it really UTI? So then it becomes very, very important for us to dig into the history of on what day did the fever start, on what time did you send the sample, and then accordingly interpret. Yes, if the urine culture is sterile, then we can stop antibiotics if there is no other pressing evolution of a bacterial illness. The viral illness will subside on its own. Let's say the urine culture came positive and we were waiting for the culture and the child's fever has gone away. Then it makes no sense to start antibiotics. So again, interpreting this flowchart is in the context of clinical, how the patient is behaving, and do not follow this chart blindly. They have said this, yes, this is important, the first point, that whenever I get a child of UTI, I need to make up my mind whether this is cystitis, a local bladder issue, or a pyelonephritis. Yes, so the child is small, is looking septic, and if there is tenderness, I will probably start this child on IV antibiotics. And depending on the clinical response, continue the antibiotics. But if it is just cystitis, now cystitis based on what? Cystitis based on symptoms, cystitis based on ultrasound, cystitis based on pustules in the urine, that has to be carefully interpreted. And if the fever runs still, then if despite hydration nothing happens, there is no other symptom, then probably I will take a clinical decision whether or not to start an oral antibiotic. One good thing that has been clearly spelled out in the guideline is do not repeat a urine culture after course of antibiotics. I think that's Dr. Deshpande has covered. Yes, but important thing is to evaluate every child, especially a child who comes with recurrent urinary symptoms or urinary tract infections for bladder valve dysfunction. So what we need to ask the parent is there beyond the age where bladder control comes, is there still a wetting of pants? Is there any Holden maneuvers? Are there lower urinary tract symptoms like hesitancy or frequency? Is there constipation? Is this child finding difficult to pass stools? Is this child passing hard stools, and is the defecation painful? If these all things are there, it is wiser to label this child as probably, we don't know UTI or no, but definitely a bladder valve dysfunction. And taking care of bladder valve dysfunction helps to decrease the intensity or decrease the incidence of probable UTI in the future. So this is again important point, that we often focus so much on the urine that we forget about the bowel. We should not be doing that. Now this recent guideline says that imaging should be more selective and less aggressive. Previously, we were told that once a child is diagnosed UTI, you do ultrasound at 3 months, at 3 weeks do MCU, at 3 months do DMSA. This was together for a child who is less than 1 year of age. A child between 1 to 5 years of age, we would say that ultrasound is definitely, so ultrasound would suffice. So the next modality, the commonest modality that we usually use is ultrasound. But we need to remember that this is an operator-dependent investigation. This investigation, I mean, most of us would just write advise USG abdomen pelvis or advise USG KUB. And then somebody comes back with a report. Unless we have told our radiology colleagues what we are looking for, they might not tell us what we want to see. So it's always better to ask for kidney sizes. If they have said there is hydronephrosis, please ask them what the AP diameter is. Please ask them what the pre-void, post-void volume is. And yes, please ask them to comment on bladder wall thickness. And we have to interpret their comment on all of these things and with clinical background. If my pre-void volume was not adequate, my bladder wall thickness interpretation goes for a toss. So all of these things have to be interpreted in light of what is happening. Now, are there any things which could suggest a probable reflux on ultrasound? Say I do not have facility for MCU in near about region. Yes, a small looking kidney, variation in renal size, either unilateral or bilateral. An abnormally echogenic kidney, a hydronephrosis which is there, which is significant, a ureter which is dilated. Now, in normal situations, ureter should not be very, very easily visible on an ultrasound. But if the ureter is appearing dilated, it probably could be suggestive of a VUR or an obstruction somewhere, or if there is a uroepithelial thickening. If a good sonologist can always tell us that the pelvic rhizal system epithelium appears thickened, and if there is any kind of bladder abnormality that is shown on an ultrasound, it tells me an abnormal bladder with or without a VUR. So this is the guideline that you can see. I'll just try to see if I can put a pointer. Yes. So ultrasound has to be done in all patients, irrespective. And like Sir said, just ask the patient to come back with an ultrasound report. The good part, it is non-invasive. Yes, but the limitation is it is operator dependent. So please have a good radiology friend who's just a phone call away bilaterally. You call him up and tell him what you want to see, and he calls you back with the findings. Now, MCU has to be done probably later, around 2 to 3 weeks of having an active UTI. Now, previously, what we used to see that MCU has to be done for infants, all infants. The recent guidelines have told that it has to be done in children aged less than 2 years with non-E. coli UTI. Suppose somebody's urine culture grew a Klebsiella. Probably in that child, you get an MCU done, and a patient with a recurrent UTI and somebody with an abnormal ultrasound. So they have reduced the indications of doing MCU from a blanket everybody to probably these few indications. The issue is not everybody does a good MCU everywhere. Now, I have had issues where the bladder was not adequately filled with the volume that was given, and hurriedly report was written as there is no MCU, meaning there is no reflux. There was no micturating film obtained, and a lot of times I ask the patient for a film that, show me the film where it is shown, and the micturating film is not there. So again, have a good trusted center to do an MCU with you. So MCU has to be done 2 to 3 weeks after UTI, somewhere and by someone who knows how to perform a pediatric MCU. Like I'm attached to a medical college where sometimes my radiology residents tell me that, sir, it is same like doing a retrograde urethrophy in adult patients, RGU. I'm like, no, you have to calculate the bladder volume and then instill the contrast media that we are giving, not just any random contrast media. So please be very careful where we get the MCU done, and it has to be done under antibiotic cover. Sometimes MCUs can give us hint like this is a scout film, or just before they have started the procedure, if there are any vertebral column anomalies, I can be able to pick them up. The child is getting recurrent UTI. On the right hand side, it shows the full-blown grade 5 reflux and probably a primary reflux in this child. Now I wanted to have a look at this film on the left-hand side. It's very smooth over nice bladder. This girl probably in February had fever episode with pyuria. Urine grew E. coli, treated with antibiotics. Big girl, 9-year-old, never had a previous history of UTI. But since February this year till about last week, this girl was repeatedly getting lower urinary tract symptoms and was started on various kind of antibiotics by, when they go doctor shopping. Everybody's starting one choice of antibiotics. Somebody got an MCU also done for her. Now, this girl was slightly on a higher side on the BMI chart. Here you can see there is no reflux that is seen both sides. There is the kidneys look okay. But here if you see, once she started micturating, this is a micturating film, some amount of contrast is going into the vagina as well. Now, this is called as a vesicovaginal reflux, which is non-pathogenic for the kidneys, but it is often seen in girls who are slightly overweight. And this causes constant wetness, dampness of the genitals, and this can cause lower urinary tract symptoms. So we need to be very, very careful while we're interpreting these reports. Coming to DMSA, the word specifically used in the current guideline is a late phase DMSA. What happens is if we do a DMSA too early, it can show me something like scarring, which I don't know whether this is a resolving pyelonephritis that was there, or is actually some scar versus some cortical dysplasia which is there. So it is important that if you have a facility, if you are sure that this was a UTI child whom you're following it up, do a DMSA after 4 to 6 months of the resolution of UTI. Please do not do a UTI earlier. In a situation where my city, my town has no facility for a DMSA, I'd rather keep a close watch on the child with seeing the growth of the child that is happening on growth chart. I'll measure the blood pressure every time the child comes, plot the growth chart for the growth, blood pressure centiles, and look for proteinuria. Because this is how I'm going to pick up the upcoming scar and a proteinuria and an at-risk kidney in case I do not have a DMSA available. Say I have a DMSA available, it is truly a scar, still I will do those same things. So these children need to be under constant follow-up with us to look for an evolving renal dysfunction. And like Sir said, all the nuclear medicine people have only seen scars. So we need to find somebody who knows how to interpret DMSs in clinical context. If the kidney is small looking and it is showing reduced tracer uptake, probably it's a dysplastic kidney and not necessarily a scarred kidney. So to summarize, most infections, if UTI, can be treated on oral antibiotics. Imaging evaluation for UTI now has become more selective, less aggressive, but we need to decide sometimes using our clinical judgment whether whom to subject and whom not to subject for invasive investigations. There is a high emphasis laid on bladder bowel dysfunction because it is known to be associated with the recurrence of UTI. An antibiotic prophylaxis is recommended for patients with recurrent UTI and high grades of VUR. I have purposely not touched upon this part in the talk because it will take one more talk. And the guidelines are not very, very clear where, because there have been contradictory statements where they've said high grades of VUR in antibiotic prophylaxis. But there's a small writer saying small children, you give antibiotic prophylaxis, younger children. So it adds to more confusion. So I have purposely kept that out of the talk. Thank you.
Yeah, thank you, Amol. And that was a good continuation to Pankaj's talk, and we got a clear picture about especially when to do the imaging and when to do the MCU. So I have one query. You said that less than 2 years, non-E. coli patient, then to do MCU. So if I have a 8-month-old child with whatever, febrile, UTI, culture positive, culture showing E. coli, and UST is showing cystitis. So because if this is E. coli, do I do MCU or I don't do MCU? Since you said less than 2 years, non-E. coli to do MCU.
As per the current guideline, the guideline will say don't do MCU. But am I sure that this was just a cystitis? Am I sure that there is no upper urinary tract problem that this child is having? I have to be sure that this child never had a febrile episode in the past. If this child is my follow-up child, and I'm sure that reasonably where this child is growing and upper urinary tract is okay, then I might wait to do an MCU. So what is your take on this?
Yeah, that's it. Because 6-month-old, we are always very worried about VUR. And before Pankaj starts saying, I will clarify that this child didn't have any other respiratory focus. Child had high-grade fever, was not a very sick-looking child requiring admission, but fever was lingering for 2 days, 3 days. Urine.
Ma'am, before sir replies, I just have one point to make. Child, how did you collect the culture? I got the bottle from the lab. Start from there. There have been various funny answers that patients give, Child started peeing, I held it in my hand and then poured it in the container. I squeezed something. So we have to be doubly sure as to how the sample was collected and when was it transported. Yes, sir.
You want me to answer?
Yes, please.
You're sure you want my answer?
Yes, yes.
See, you need to understand the logic behind what they are saying. What they are basically trying to tell you is that if the ultrasound is normal, don't do an MCU. Forget about E. coli, non-E. coli and all that. Okay. Now, my question to you is, suppose you do an MCU and you find a MCU grade 3 reflux. When was this reflux present in an 8-month-old child? When did it first start?
Difficult to say.
It started at birth. So you doing an MCU at 8 months of age and showing me that there is grade 3 VUR in the child, how does it help? Why did the child not get a UTI in the first 8 months? And after 8 months, now you are saying that the child is going to be at risk. You need to understand that reflux is present in normal population also. Just because reflux is present, they don't necessarily get UTIs. As he very clearly mentioned, bowel bladder disturbances are the reasons why you get UTI, irrespective of whether you have reflux or no. So you identifying reflux is not necessarily going to change your management in any way. So prophylaxis in the past was given till 5 years of age, 7 years of age, because the kidneys are vulnerable, immature. They are more likely to get scarred. That is no meaning. Today, prophylaxis is for a period of 1 year at the most if it's an infant, or 6 months if it's an older child, till we sort out the bowel bladder habits. And then prophylaxis stop. Nobody keeps on prophylaxis throughout life. So what they are saying is, if you see dilatation on an ultrasound, then you are justified in doing an MCU, because it's very likely high-grade VUR and you may keep on prophylaxis. But even in high-grade VUR, you're not going to give prophylaxis forever. It's only for a short time to make sure that the child doesn't get repeated
I'm
UTIs.
missing a huge number of VUR by not doing. At a personal level, a 6-month or an 8-month-old, I feel I will definitely do a MCU. Because
No, but so what you're trying to say is, if you have VUR, you're more likely to have damage in the long term.
Maybe.
No, that's the whole point. No. So now I have to start telling you what was the incidence of CKD 20 years ago. What is the incidence of CKD today? Despite all the reimplantation done, this is not Dr. Deshpande talking. He's a madman anyway. Forget me. The data that has come out for CKD patients, for pediatrics, for children, has very clearly made a statement that the hope for reduction in CKD numbers by treating VUR has not occurred. So VUR was never the problem. It was always dysplasia. It was always that the kidneys had not formed. And our focus, we keep on moving towards VUR. VUR has never been a problem. I've said this for 20 years since the time I've come here, that it is the kidneys that you need to look at. It is not the VUR part. VUR does not cause UTI. It can worsen a UTI. The cause of UTI is a bowel bladder disturbance. So if you get that better, you will never get a UTI. So unless VUR is associated with an obstructive element, so for example, PUR, or you've got high-grade VUR with high volumes causing secondary damage to the kidneys, the kidneys will never suffer because of VUR.
Okay, since Amol said covering about prophylaxis and all itself is a very long talk, but I think at least some basic message we need in this session about prophylaxis. Because last week I had a 7-year-old child with 3 episodes of culture positive UTI in the last 6 months. Okay, 1 year back, this child was admitted in our PICU with acute encephalopathy and she got encephalitis, post-viral, and all. So parents are always on the edge. She doesn't have any constipation. Now 3 episodes in 3 months. So in this child now, obviously I have to go ahead and do further MCU or whatever DMSA.
Is the ultrasound normal?
The ultrasound showed
Was the ultrasound normal?
No. The 3rd episode was also not normal and the 2nd episode was also not normal, but same thing, cystitis, bladder trabeculations. Now, this is a 3rd episode, just oral antibiotic treatment is going on. Now, next week she'll come for a follow-up. So how do I go about now? Do I put her on prophylaxis? Because, Pankaj, if you remember when we were at MGM, many times we would give them Septran or Cephalexin single dose. So all those things are now no longer followed. So as general pediatrician now, what do we do?
I will let Amol answer, but before he answers, suppose you have done an MCU and the MCU comes normal. What are you going to do?
Sorry, sir.
I'm not.
No, I would put the child on.
To ask Shilpa. I said you will answer the question.
I asked you.
You do an MCU today. You said you're going to get an MCU. MCU is normal. Now what are you going to do? I'm asking you, Shilpa, not Amol.
I think still we should put this child on prophylaxis because
absolutely right.
6 months and a 7-year-old is
absolutely. It has no relation to VUR.
Yeah.
I'll let Amol answer. Yeah.
So in a older girl who's coming back, and let's say we have done MSU and there is no viewer, I would still want to focus on treating a bladder bowel dysfunction if it is there, and take every effort to identify and treat it. Then, right from showing them Bristol stool chart to hygiene measures to urine hygiene. Like a lot of these older girls, they don't use school washroom because the washroom is dirty. They keep on holding on to their urine, and this
Coming
makes
to
them more and
hygiene,
more.
a lot of our patients ask us for the adolescent and that 8 to 15 years that whether they are supposed to use those fancy V-wash kind of preparation, I mean, any benefit. And second, the elite patients, the one we see here, they have, girls especially have the habit of using jet sprays after every peeing. So, I mean, how do you address these two things?
Definitely not indicated to use the hi-fi vaginal intimate hygiene products in pediatric age group. Definitely no, it alters the pH. Okay. I mean, they're getting into adolescence, not recommended to use them. Jet spray, again, is depending on, it's a personal question. I don't think it adds more to the incidence of UTI if you're using a jet spray after passing urine.
I think the short answer here is it's a UTI mimic. So both of those cause vulval redness. When you get vulval redness, these children get dysuria. Then you do a urine routine, it shows 20 to 25 pus cells. And then when you send a culture, it comes positive. So all these girls, I get treated for UTIs for 6 months, 1 year continuously. So repeated washing is the commonest cause of vulval redness in girls. And it is UTI mimic 1. So I told you I am not going to talk about UTI mimic. That's a different talk. I'll come and talk about it some other time. But that is the commonest reason for symptoms in an older adolescent girl. The second is detrusor instability. So they all get abnormal urine reports. They all get treated as UTIs. They never have UTIs. Just like the other girl that one of your doctors asked me. So vulval redness comes because of repeated washing. You need to understand that the cycle is ulta. It's not that they are washing. It's because they have vulval redness, they get burning, and therefore they are using the jet spray to cool that area because they think that helps to cool it down. So the pain, the dysuria that is present in this girl is not only during voiding, it's present throughout the day. In fact, a typical history is रात्री 2 वाजता उठली आणि रडायला लागली तिकडे दुखायला लागलं. Why should a UTI cause that? This is plain and simple severe vulval redness which they are getting. So no to both of them. So unless they go for a bath or they go to pass stools, there's no need to wash.
And we didn't answer our previous question of what is, I mean, you can at least tell us about 1 or 2 drugs which are safe and which can be used as prophylaxis in recurrent UTI.
In younger children, in neonates and infants, probably cephalexin is a good choice to give at 10 milligrams per kg, once a day dosing. Older children, yes, I have option between nitrofurantoin and Septran to give. Nitrofurantoin was not very easily available a couple of months back. It is now available. But the complaint that parents come back is child vomits after taking nitrofurantoin. That is one frequent complaint that I have got. So Septran or nitrofurantoin is a good antibiotic choice for prophylaxis in older children. Younger children, probably cephalexin.
How long to give?
So the prophylaxis, if you go to look at your textbook from that time, the ideal agent should be cheap, safe, not changing the periurethral flora. Only 2 antibiotics do that, trimethoprim and nitrofurantoin.
Correct.
So they are ideal. Unfortunately, both are not easily available in India. You don't get trimethoprim, you get Septran. And nitrofurantoin is a very pukey medicine. Have you ever tried tasting it? Try karke dekho. It's whatever flavor you get it in, it's pukey. So that's why we have to use a different one. So cephalexin is not ideal because it changes the periurethral flora. So you're more prone to getting worse infections, but then we are forced to use that. So 10 to 15 milligram per kilogram once a day. As I said, 6 months, maximum 1 year, we don't give it beyond that.
Yeah.
I had one question that so now the dictum is for urine culture, 10⁴ is taken as positive culture now.
I think you need to look at the symptoms rather than the culture. I would still go for 10⁵ because we are saying contaminant organisms can easily grow up to 10⁵. But urine culture can grow only up to 10⁴. That sounds very discordant to me. But yes, the guidelines are saying 10⁴.
And first choice of oral antibiotic?
No,
Oral antibiotic?
I know the guidelines have given 3 or 4 antibiotics. So cefixime, augmentin, any of those are perfectly fine.
Can we use cephalexin?
Yes, they have said cephalexin can be used as treatment.
Okay.
In prophylaxis, the other thing to remember is there's no need to rotate antibiotics. You give only one antibiotic. And if you get a UTI with an organism which is resistant to the prophylactic antibiotic, you don't need to change it after that. Unless you get repeated infections, you don't change because you're not covering that particular bacteria. You're trying to cover 90% of the bacteria.
Yeah, this is what I was going to tell, that the commonest error which we do is we start with whatever the first line antibiotic as per the guideline. Child is responded also asymptomatic or febrile, and on the third day they come with a culture report where it shows that resistant to cefixime, which I've already started. But if the clinical response is there, I will not change and I will continue cefixime, right?
Yes.
Okay. Any other questions anyone wants to ask? You can either ask questions, we can take for 5 minutes more, or you can type. Preeti, Sushmita has asked, how do you treat detrusor muscle
Instability. Detrusor instability.
Muscle,
yeah, it's basically irritable bladder. So you need to first get a good history, make sure that it is that before you start treating it. Because the commonest cause of detrusor instability is constipation or using drinks like tea, coffee, and fizzy drinks. And the typical history is the child is left at home with the grandparents who take tea, and therefore the child starts tea, and therefore the child gets it. And they keep on getting diagnosed as urine infections. So some of these children may need anticholinergics, and no, you don't need urodynamic studies.
Preeti is asking first line of choice of IV antibiotics in proven urosepsis. Yes, we often do have some controversy in our unit when it comes to.
I'll let Amol answer that.
I would want a broad spectrum antibiotic which is not very, very high-fi. I'm happy to start with ceftriaxone.
Yes.
100
I think what is commonly happens outside is 2 antibiotics, and I've never understood why. If you think you're treating urosepsis, I think if you're treating any other infections, you may have a logic. But if you're treating a urine infection, a single antibiotic is what has been said everywhere around the world. You don't need 2 antibiotics.
Okay. Any other questions? Else I will conclude, but I'm going to revise, at least it's for my own self also, whatever I've learned, and for a few doctors who joined late, what are the take-home messages that we learned today? I started the talk saying that we were in an era of under-diagnosing to now we are in an era of over-diagnosing UTI. So the point made and what we learned is we do not follow blindly any protocols, whether it is 2023, 2024, ISPN or NICE or whatever. I think no one cap size fits every patient. So we need to look at the clinical history and the clinical symptoms. The ideal time is in fever without focus at 48 hours. We wait for first 2 days, and after 48 hours, we send the urine routine report. Unless the child is really very, very sick, and if the urine routine report is showing 5 pus cells in a centrifuge sample or 10 pus cells in a non-centrifuge sample in a sick febrile child without focus, I would start the antibiotic, and I would see the clinical response to the treatment. The duration of antibiotic depends on, again, the clinical response to the treatment. If my culture is negative and if I'm not getting any other focus, then depending on the child's response, I will decide whether to give 5 days or 7 days of antibiotic. A positive urine culture need not necessarily be labeled as UTI, is what I learned from Pankaj today. And this line I'm going to, keep myself reminding every time. Again, a cystitis report by a sonologist did not necessarily mean a UTI, which also we learned. Timing of sampling and collection. So I think in our OPD, we need to spare 30 seconds extra to educate the parents about the right technique to collect the sample at home if they are OPD patients. And if they are not going to submit immediately to the lab, we advise them to keep the urine sample in the fridge. I don't know how many Indian people would like to store urine in their regular fridge where they keep their food also, but at least we should start doing that. And yeah, what Amol said was, and we also practice in our unit, constipation is very, very important. And a lot of time in treating UTIs, we often forget to treat constipation. So it's very important that every patient of UTI, we look into their bowel habits also. And if there is history of constipation, we treat that also. So wonderful. My doubts are filtered, and I think we got a good clarity to treat pediatric UTIs and follow streamlined patient-based protocols rather than following, just a narrow vision. So
Elementary, my dear Watson.
yes,
Keep logic.
What's friend?
So guidelines don't mean you stop thinking. That's the answer.
Yes. So Preeti, do we have clarity now? And I hope we'll have common consensus at work also.
Sure, ma'am.
Okay. Subhash, you want to ask anything?
And it's pretty crystal clear.
Okay.
Yeah.
Thanks.
Nice.
So on this note, thank you so much, Pankaj and Amol, for sparing time. And in fact, you are the opening batsman of our pediatric KAIZEN series. A lot of people ask me why the word KAIZEN, so I will just take an extra second. That KAIZEN is a Japanese word. And, post-COVID, we all are spoiled because I think attending physical CME for 3 hours, 4 hours, utna attention span aajkal rehta nahi hai. So we thought we'll start with this kind of monthly online webinars and small doses of learning and small doses of improvement. So thank you, and we hope that this KAIZEN series continues. And next month we'll again come again with something interesting and interactive. And thank you all friends and colleagues who have attended. I can see many familiar names here, and even from my alumni Sion Hospital.
I had a small suggestion that since we have already finished UTI, in the next session, why don't we talk about bladder ball dysfunction from the pediatric nephrologist? How to manage that?
I think it will be overdose. No, she's saying small
No,
dose.
after 1 month. After 1 month.
You need some other specialty. Rotate and come back.
By the time you would have forgotten the guideline.
No, but that's what she's saying. So small doses of different specialties.
Okay, fine.
We will get the mosquitoes next month because probably with the monsoon, we'll have more confusion to treat the mosquito-borne illness. So